Assalamu alaikum everyone, my name is Jenan and I'm going to be discussing and explaining about the calcium metabolism. So before we start getting into the metabolism, first of all, a very important thing to know is that calcium is one of the most important minerals in our body. It constitutes about 40% of all of the minerals that we have. And regarding its distribution, 99% of it will be found in our bone and teeth, and only 1% is found in blood. But that 1% is the 1% that the body will continuously regulate and continuously monitor and try to maintain it in the ideal level, which we'll talk about soon. Now, regarding its function, the most obvious function is the fact that it is a bone component. So calcium is one of the most important components when it comes to looking at bones. But it also has many other functions, including muscle contractions, nerve impulse, blood clotting, hormone secretion, like in the case of insulin, and a secondary messenger. Calcium is absorbed via simple diffusion or active transport, and it will be excreted via the kidneys. And as logically, you would assume that calcium would be found in dairy products and obviously some greeny vegetables. So regarding the concentration of calcium in the blood or in the plasma, the ideal concentration would be somewhere between 2.2 to 2.6 millimole per liter. And anything outside that range would be abnormal. So if it was below 2.2, well, that would be the case of hypocalcemia. And if it was above 2.6 millimeters per millimole per liter, then that would be hypercalcemia. So in the case of hypocalcemia, usually it can be due to a deficiency in vitamin D or the parathyroid hormone, and that would be, it makes sense why when I start explaining about the metabolism. Kidney and hepatic failures can also cause hypocalcemia, and that is linked to vitamin D deficiency. High fatty foods and fibrous food, and this is because these foods lock calcium. Then if there is like an increase in phosphorus levels, polyphenols, which are basically like tannins that are present in tea, menopause, and even aging are all possible factors that can possibly cause hypocalcemia. In the case of hypercalcemia, it is mainly due to opposite factors. So usually if there is excess in vitamin D, or hyperparathyroidism, which is more common than hypervitaminosis D, or an overactive thyroid gland. Now, when it comes to hypocalcemia and hypercalcemia, they are regulated by certain hormones and vitamins in our body. Hypocalcemia is regulated by the parathyroid hormone and vitamin D, and hypercalcemia is regulated by calcitonin. So evidently, you can see that hypocalcemia is regulated by more structures or by more hormones, and this is mainly because the signs and symptoms that correlate with hypocalcemia are a lot more dangerous than that of hypercalcemia. Hypercalcemia isn't as worrisome and as dangerous as hypocalcemia. So usually acute hypocalcemia is the one that you'll see more symptoms that can range anywhere from paresthesia to spasms, cramps, tetany, and even go as far as a person experiencing seizures in the case of hypocalcemia. Whereas in the case of hypercalcemia, usually the symptoms aren't as severe as hypocalcemia. Some symptoms include nausea, vomiting, fatigue, problems in the muscles like weaknesses and twitches, and bone pain and frequent fractures. But for the most part, hypocalcemia has so much more severe symptoms and signs. So when it comes to regulating any substance in our body, the main way that the body will regulate it is in 3 different means. So it will focus on absorption, the absorption of that substance, so through the intestines, and then excretion, and that would be via the kidneys in the case of calcium, and the distribution of it. So as we said, calcium is mainly found in bones and teeth, and then the other part, or the 1%, is found in the blood. So usually when it comes to regulating calcium, we're looking at the intestines for absorptions, the kidney for excretion, and the bones for the distribution of calcium in the body. So as we said, we have 2 main cases of the level of calcium in the body. We can, in abnormal level, we can either have excess, where it's above 2.6 millimole per liter, and you can have it below 2.2, and that is hypocalcemia. And because hypocalcemia is far more dangerous than hypercalcemia, it's regulated by 2 main compounds, which are vitamin D and parathyroid hormone. So we'll start talking about vitamin D, which is the first regulator in hypocalcemia. Vitamin D is, as the name suggests, a vitamin, so you'd expect it to be found exogenously. But vitamin D is also produced endogenously, hence why sometimes it's referred to as not a strict vitamin, because ideally vitamins are always compounds or always structures that you have from external resources like supplements or from food. But vitamin D is also found endogenously, and this is via the cholesterol pathway. During the cholesterol pathway, there is a certain metabolite called 7-dehydrocholesterol, which can get converted to cholecalciferol via UV exposure from the sun. So when your skin gets exposed to UV, this compound, which is a metabolite during the cholesterol pathway, will get converted to cholecalciferol. Exogenously, there are plant sources and animal sources like from liver, beef, eggs, and so on. But unlike calcium or dairy products, were a very crucial source or a source of calcium or a very important source, dairy products are actually a poor source of vitamin D. But plant sources will give ergocalciferol, and animal sources will give cholecalciferol. In all cases, be it endogenously or exogenously, ideally the body should receive cholecalciferol. This is the inactive form of the vitamin, or it's the D3. This inactive form isn't actually the form that will cause the effects on calcium, but if a person was to take supplements of vitamin D, this is the form that the body will be taking it as. So that's the cholecalciferol, or the inactive vitamin D. So to activate it, it's done in 2 separate organs. It will be converted in the liver, and then it will go to the kidneys to give us the active vitamin D, which can actually do the function and do the job. So first of all, cholecalciferol, be it from endogenous or exogenous sources, it will be converted to 25-hydroxycalciferol via a certain enzyme that is present in the liver called 25-hydroxylase. Then it will go to the kidneys, this 25-hydroxycalciferol, and it will get converted into 1,25-hydroxycalciferol or calciferol via 1,25-hydroxylase. So initially it will go to the liver, and via 25-hydroxylase, which is the enzyme, it will convert it to 25-hydroxycalciferol. Then it will go to the kidneys via 1-hydroxylase, and it will get converted into the active form, which is 1,25-hydroxycalciferol or calciferol. So now vitamin D is activated. So initially it was cholecalciferol, then it goes to the liver, becomes 25-hydroxycalciferol, and then it becomes 1,25-hydroxycalciferol or calciferol, which is the active form. So ultimately, now we can look at the action of vitamin D, or what does vitamin D, how does it impact calcium? So as previously mentioned, whenever we're looking at any certain substance in the body and regulating that substance, we're looking at absorption, excretion, and distribution. So vitamin D, the whole aim of it is it needs to increase the amount of calcium in the body, because it's going to be synthesized, or it's going to be needed when the body has low level of calcium or during hypoglycemia. So this, when we're looking first of all at absorption, the main way that vitamin D works is it will increase the absorption of calcium in the intestine from exogenous sources. So what vitamin D does is there are certain transcription factors that are present. So basically vitamin D will go to the enterocytes, and it will increase those transcription factors to ultimately increase the amount of a certain protein. It's a carrier protein for calcium, and it's called calbindin. So basically to summarize it, the whole role of vitamin D is to go to the enterocytes and then ultimately it will increase the amount of calbindin, which will increase the absorption of calcium in the enterocytes, or increase the amount of absorption from exogenous resources. So now whenever you're taking food sources that have vitamin D, that have calcium, vitamin D will increase the amount that is going to be absorbed from these food sources. Regarding excretion, the whole thing with vitamin D is it needs to decrease the excretion or increase the reabsorption. So it wants to minimize the amount of calcium being excreted from the kidneys. Now regarding distribution, the main way vitamin D is going to work is it wants to increase the amount of calcium in the blood. So what it does is it will activate the bone-eating cells, or basically it will activate the breakage of the bones to release the calcium stored in bones and ultimately put it in the blood. And this is what we call resorption. So vitamin D will work via increasing resorption to have more calcium in the blood. So overall, the whole point of, or the whole role of vitamin D when it comes to controlling calcium is increasing the amount of calcium in the blood, be it via having more calbindin, and so increasing absorption in the intestine, or decreasing excretion, and so increasing basically reabsorption, or via increasing resorption, so that there's more calcium in the blood. Now, there are certain pathologies or certain abnormalities when it comes to the level of vitamin D. So we can have a deficiency in vitamin D, or we can have a toxicity in vitamin D. Normally, the more common one is deficiency in vitamin D. Toxicity is very rare, and it's usually more associated with supplements rather than food. So when it comes to deficiencies of vitamin D, it's usually because of abnormal sun exposure, so the person isn't getting enough exposure, so the body isn't converting 7-dehydrocholesterol to cholecalciferol, and so you're not having endogenous form of vitamin D. Malnutrition, problems in the kidneys and in the liver, so ultimately the body cannot convert it from the inactive to the active form, and other reasons ultimately stemming and resulting in deficiencies. The main examples when it comes to, or the main pathologies that would arise from a vitamin D deficiency is rickets and osteomalacia. And basically the main difference is the age groups that they affect. Rickets will mainly affect young children, whereas osteomalacia is mainly affecting adults. And the whole idea is that both of them will affect, because you will have basically a decrease in the amount of calcium in the body, because you don't have a compound to increase them, because that's the whole point of vitamin D. So ultimately the bones will become very fragile with rickets, because it's in children, the bones aren't growing properly, whereas with osteomalacia it's more of like the bones are becoming soft, and because of lack of vitamin D, and ultimately there's nothing to raise the calcium level. So this is in the case of deficiency. In the case of toxicity, where the person has excess amount of vitamin D, this is again, as previously mentioned, it's rare, it's not as common as deficiency of vitamin D. And this will result in a condition called hypervitaminosis D. And it's usually because of supplements, usually because the person is taking excess supplements with a very large dose. And so ultimately it will result in hypervitaminosis D. And it will, on the long run, result in hypercalcemia. And as previously mentioned, hypercalcemia will usually result in problems like nausea, vomiting, problems in the muscles and weaknesses and so on. But for the most part, this is because the idea, again, vitamin D, the whole point of it is to increase calcium. So when we have a deficiency, you'll probably have hypocalcemia. And if you have excess of it, then you're going to have hypercalcemia. And so the symptoms and the signs that are explained in the conditions make sense when it comes to looking at calcium and the function of vitamin D. So that is the first regulator, which we spoke about, which is vitamin D and its role in increasing the calcium level during hypocalcemia. The other metabolite, or the other structure, or the other hormone now that would increase calcium level during hypocalcemia is the parathyroid hormone. So it works very similar to how vitamin D works, but with a few exceptions. The parathyroid hormone or parathormone is a hormone that is going to be released by the parathyroid glands, and it's a peptide hormone made up of 84 amino acids. Again, the whole point of parathyroid hormone is similar to vitamin D. When the person is experiencing hypocalcemia, there is low amount of calcium in the body, the point of this hormone is to increase the level. Coming back to the whole idea, when we're regulating a metabolite or regulating a substance, we're looking at absorption, excretion, and distribution. The main difference is with absorption. PTH, or parathyroid hormone, doesn't actually directly affect absorption. Instead, what it does is it goes and targets the kidneys and activates a certain enzyme called 1-hydroxylase. And this, if you recall, is an enzyme that's important for the activation of vitamin D. We said that vitamin D, initially in its inactive form, cholecalciferol, it goes to the liver, becomes 25-hydroxycalciferol, then goes to the kidneys, and via the 1-hydroxylase becomes 125-hydroxycalciferol, which is the active form of vitamin D. So what parathyroid hormone does is basically further activate that enzyme in the kidneys to increase the amount of vitamin D, or increase the synthesis of vitamin D, and ultimately vitamin D can then go and then have calbindin, and then calbindin will increase the absorption. So parathyroid hormone doesn't directly target enterocytes, but it activates vitamin D, which then can go and produce more, basically have more calbindin, more absorption. Excretion and distribution is the exact same way, more or less, the way that vitamin D works. So it will decrease the excretion by increasing reabsorptions in the kidneys. So you don't want to excrete as much calcium, you want to maintain the calcium. But parathyroid hormone will also affect phosphate. As for the distribution, PTH, or the parathyroid hormone, will also increase resorption. So we're going to break down the bonds to release calcium in the blood by, again, activating and increasing the number of osteoclast cells. So again, parathyroid hormone, similar to vitamin D, the whole point of it, or the whole role of it, is to increase the amount of calcium in the blood, or to increase the calcium serum concentration. Similar to when we spoke about vitamin D, you do have deficiencies and toxicities when it comes to parathyroid hormone, but unlike vitamin D, where we said deficiencies are more common, usually hyperparathyroidism is more common than hypoparathyroidism. Hypoparathyroidism is basically not a very common condition that's present, but it will result in a low calcium level, similar to how low level of vitamin D will result in low calcium. And again, hyperparathyroidism will also result in high amount of calcium, like hypervitaminosis D, and the symptoms will be very similar. but you can see in hyperparathyroidism, it might even cause osteoporosis. The last hormone that we'll be talking about is calcitonin, but unlike PTH and vitamin D, calcitonin is released during hypercalcemia. So the hormone calcitonin is a peptide hormone. It's a 32 amino acid peptide hormone. It's released from the thyroid gland, and the whole point of it is to decrease the amount of calcium in the body, unlike PTH and vitamin D, which work to increase the amount of calcium. So when it comes to looking at absorption, excretion, and distribution, calcitonin does not have any effect on absorption, and its effect on excretion and distribution is the opposite of PTH and vitamin D. It will basically increase the excretion, so it's decreasing reabsorption, so it doesn't want to maintain any of the calcium. It wants to excrete as much of the calcium as possible to decrease the calcium level. And with distribution, it will inhibit resorption. It doesn't want to break down bones and release calcium, so it's inhibiting the functions of osteoclast cells or the bone-eating cells, so that we don't want any more calcium coming into the body. So overall, the point of calcitonin is to decrease the calcium level in the body and try to inhibit any further increase by increasing excretion and inhibiting resorption. So to summarize everything that we've mentioned, calcium is a very important mineral in our body that constitutes about 40% of all of the minerals, and it has so many important functions, like being a very important bone component, very important for nerve impulse, muscle contractions, and so on and so forth, and mainly regulated by 3 main compounds. During hypocalcemia, because it has so many more dangerous symptoms and signs, we have 2 main regulators, whereas in hypercalcemia we only have 1 regulator. And when it comes to regulating any substance in our body, we're mainly looking at the absorption of the metabolite or of the substance, the excretion, and the distribution. So vitamin D and PTH are going to work to increase the level of calcium, whereas calcitonin will work to decrease the level of calcium. Vitamin D will increase the absorption from the intestine. As we said, it will basically target transcription factors, build enterocytes, which will increase a certain carrier protein called calbindin and ultimately increase the absorption. Whereas PTH works it works indirectly via activating 1-hydroxylase, which will produce more vitamin D, and then vitamin D can do more of its function. Whereas excretion and distribution are the exact same thing for vitamin D and PTH. For excretion, they want to decrease the excretion of calcium, and they want to increase the reabsorption. So they want more calcium to be maintained in the body. And distribution, they will both increase resorption. As for calcitonin, it doesn't have any effect on absorption, and the function of it, or the activity or the impact of it on excretion distribution, is the opposite of PTH and vitamin D. So it wants to increase excretion as much as possible and decrease reabsorption, so that we have more calcium leaving the body and we're decreasing the amount of calcium. And then finally, with distribution, it will decrease resorption, so that we do not have any more calcium entering the blood from bones. So this is in a nutshell what every single one of them does and how it regulates calcium when it comes to absorption, excretion, and distribution. Thank you.